Hello everyone. Good afternoon and good morning to our guests from US and UK. I hope you are all doing good in this pandemic crisis. Please take care of your health first. My name is Sanjay. I head the healthcare vertical at ITP Media Group and I'll be your host for today's session. It gives me immense pleasure to welcome you all on behalf of ITP Media Group, which is the largest foreign publishing based out of Middle East. We do over 100 titles in various industry verticals. And in India, we do 7 titles for the industries. And Healthcare Radius is one of our leading publication, which has focused content, stories, latest stories on the healthcare segment in India. I would like to give focus on today's webinar for which we are here today. COVID-19, the super pandemic, which has taken the entire industry, entire humanity on its feet, and our healthcare workers are really struggling to give their best possible efforts to help our people on the infection control. Looking at the Healthcare Radius series, what we are focusing today, which is fighting the pandemic, our topic and theme for today is new design and construction for the infrastructure in healthcare. Before proceeding with the webinar, I would like to talk about more on the certain features on this webinar. What are the certain announcements which you can take into for this session? For any questions with related to the webinar, to our esteemed participants, please do tap in your Q&A tab on your screen and post your questions, and we will try our best to reply most of the questions. In case there is any communication error or any drop in terms of the audio video issue, please do send us in your chat. We will try our best to reply as soon as possible. In the course of the session, we will be having a poll which will have talk about today's session. Please do cast your poll for which will appear in your screen, and we will show the results later on our website, healthcareradius.in. Before I proceed further with the session, I would like to introduce Mr. Bibor Srivastav, who is our Group Publishing Director for ITP Media India, and he will be our host and moderator for the next session. And let me hand it over to Bibor further. Thank you.
Absolutely. And Sanjay, thank you for bringing this to here. I just want to check with my eminent panel. Am I loud and clear?
Yes.
Awesome.
Yes.
And would request the gentleman and the lady to keep the mic, the mic on the mute. Requesting everybody to keep the mic on mute so that I can come to you, and I think we have a absolute, clear, loud, audible conversation. And before I get into the discussion, it's my privilege to introduce such an eminent panel, which is virtually coming from all parts of the geography of this globally. And I think I'm actually one for looking for an interesting interactive session and a very engaging and knowledgeable session that we all get enriched. With us, we have today Dr. D.S. Rana. He's a renowned nephrologist and the chairman of Sir Gangaram Hospital, New Delhi. The government of India awarded him the 4th highest civilian honor of the Padma Shri in 2009 for his contributions to medicine. Dr. Rana, thank you. We are all so proud of you, sir. Dr. Ashutosh Raghuvanshi took over as a Group CEO and MD of Fortis Healthcare Limited in February 2019. Prior to that, he was the Vice Chairman, Managing Director and Group CEO of Narana Hridaya for 18 years in the past. Dr. Raghuvanshi has been associated with the Bombay Hospital, Apollo Hospitals, Vijaya Heart Foundation, and Manipal Heart Foundation. Ladies and gentlemen, that is Dr. Ashutosh Raghuvanshi. Next up, a name which is globally very well recognized, Shawn Basler. AIA leads the global architecture and design firm Perkins and Eastman as co-CEO with two other members of the firm's leadership team, responsible for fostering Perkins and Eastman national and international growth. Shawn is a leader in the design of globally recognized architecture and planning projects. With more than 20 years of experience, Shawn is a member of the American Planning Association and is also on the professional advisory board of Kansas State University College of Architecture, Planning and Design. Thank you, Shawn, for being with us. Payman Askreenejad, founder and president of PAN Partners with 20 years of progressive design and construction management experience, of a showcase of internationally renowned complex concrete and steel structures. Throughout his distinguished career, Payman has dedicated himself to structural innovation. His best known contribution has been to develop the hexagrid structural systems for the tall building. And ladies and gentlemen, he had a long profile, but he said, Vibhor, less is more. So Payman, that's the small and the tallest building, Burj Khalifa, goes to the credit of Mr. Payman. Next up, we have Mr. Ted Jacob. Mr. Jacob has over 40 years of design and construction experience. He's the president and founder of Ted Jacob Engineering Group as an international design firm with corporate office in San Francisco, Dubai, Singapore, and other branches around the globe. He's been a guest speaker at many health conferences in Dubai, Mumbai, Singapore, and Beijing. He has grown Ted Jacob Engineering Group from a startup firm to an industry leader with a solid reputation in the design of healthcare, higher education, mixed use, and hospitality type projects throughout the world. Thank you, Mr. Ted. Next up, we have our very dear friend, Reza. Reza Kabul is an architect who exhibits creative abilities along with practicality in order to create both stylish and easy to use buildings. A good knowledge of the various facets of aesthetics, cost efficiency, latest trends in design, materials, and other legal regulation add to his advantage. Well, ladies and gentlemen, the only lady which I come to is Rita Datta, who is the editor of Healthcare Radius. And, I would like to kick off. And I just thought in the moment where we are, I was reminded of a very interesting quote of a famous Irish politician from the previous century, Mr. J.J. Walsh. He said, "It's sometimes as dangerous to be run into by a microbe as by a trolley car." Just in case people have not been able to listen, I repeat one more time. It is sometimes as dangerous to be run into by a microbe as by a trolley car. Well, absolutely, really contextual, really what we're experiencing. Couldn't have been better to look at this. And I would like to very quickly go to Dr. Raghuvanshi and to Dr. Rana to begin with. Sir, you are actually in the whole thing at the moment. It has caught something out of the blue. What is that, Dr. Raghuvanshi, what your thoughts were, and how did you are putting together your resources, your energies, your people, your whole machinery together to fight this pandemic?
Yeah, so as you said that this is something out of the blue and it is unprecedented. But the matter of fact is that from historic times we are aware that a pandemic or an epidemic can hit any time. And I think from 2002 onwards, it has been very, very eminent. So I think in our subconscious, everybody was to some degree wondering when it is going to happen and not whether it is going to happen or not. But the question was only when. I think from December, from early January, I think it was very obvious that it is coming to us as well. So I think from February, early February, we started planning. The first thing we tried to put in place was the supply chain because we felt that that might get disrupted. Our needs might change dramatically in terms of what we require, in terms of PPE, etc. And also at the same time, we felt that there are going to be challenges of flows, etc. And then infrastructures have not really been prepared for handling a large number of patients who are infected. So adequate number of isolations are not there. and all those challenges are there. And then there is a people related issues, because your frontline workers are at severe risk, and that can seriously impair how your functioning is going to be. So we did create some kind of internal process where we divided the teams into sub-segments, so that we don't put all of them at work together. So these were the few things which we started with planning in February.
Dr. Rana, what's your take, and what would you like to make comments on this?
I will say, unlike Dr. Raghuvanshi, those who were already preparing, making preparations since January, we started suddenly when we were given call in the mid-March that we require to be prepared to fight corona crisis. And I think we have very successfully prepared ourselves during last 6 weeks to join the government to fight this crisis. We have separated one of our hospitals. We have got actually 3 hospitals, one main Gangaram hospital and 2 more hospitals which are situated on different locations, that is in Pusa Road. So firstly, we have offered only 42-bedded hospital for this service, which was very easy to prepare. And within 3-4 days, with the help of our maintenance officer and engineers, we could do all what changes were required in that small building. But unfortunately, that hospital is now full, and we are preparing now another hospital, which is 142-bedded hospital, and which will be ready by tomorrow. For last 7 days, we are preparing and doing certain alteration in order to meet the requirement of ICMR guidelines. So we are fighting, but I am very glad that people like Dr. Raghuvanshi, they were already aware of this situation since January, and they prepared well. But we started only 6 weeks earlier, but we are fighting.
All right. So very interesting thoughts by Dr. Raghuvanshi. He talked about the inadequacy of the infrastructure. Dr. Rana said that, we got in mid of March, the preparation to fight, but they're now full steam. The whole team is like working as one cohesive force to fight this pandemic. Payman, this brings us to a question. How, your projects you're looking, especially from the healthcare aspect, how are the spaces that you're defining, and how are the new projects post-COVID? Mike, Payman, your mic.
Yes. Yeah, sorry.
This is the new thing. This is the new thing we are also adjusting.
Yes, absolutely. Well, thank you for having me. It's a great honor to be a part of such a distinguished panel. So, yeah, today isn't the first time a traumatic event has affected the build environment. So if I go through just a very glance through the history, it was cholera that influenced the modern street grid as 19th century epidemics prompted the introduction of a sewage system that required roads above them to be wider and straighter, along with the new zoning law to prevent, overcrowding. So, and then after that, it was a plague pandemic in 1855 in China, which introduced, drain pipes to building foundation, drastically change, the design aspect of the whole system due to the rats, global war against a rat. And obviously now we have this pandemic, which none of us were prepared for it. But now I think the design industry should looking, to the newest strategy and how to, face similar dilemma. So let's look at it this way. When we return to our offices after the quarantine period is over, do we want to continue living in isolation, or will we work equilibrium through the design? So as a designer, we embrace solutions. So that leverage our knowledge and abilities to provide safeguards for building user and inhabitant. So it doesn't matter, it's a hospital, it's a building, so whatever it's related to design. So that's why we as a designer, we have to look, in a better way how to mitigate, these, pandemic and issues coming from it. So I'm going, to highlight our perspective. So in our company, which we are working diligently, so how we can prevent, such things in our future designs. So first, we have to specify the smart materials. So we must, as a designer, prioritize materials that are easy to maintain, resist mold, and also promote good indoor air quality. There will be a demand for products and technology designed to sanitize the surfaces. I know many manufacturers are already integrating, antimicrobial coatings onto their interior products, such as like a flooring, door hardware, facade and window shades, paint and furniture. So you can name it. Now they start, implementing all of those in their products. So we can also leverage materials that are inherently antimicrobial, such as copper. So we have to look at those kind of material. So there are lessons to be learned, of course, from the healthcare sectors. So, and that's why we have such expert teams in this panel also to listen to them, to the doctors, to others, so we can, as a designer, to incorporate in our workplaces and also indoor environment. The other one, increase the ability for the hand washing and sanitations in our facilities. We have to have now more of them, in our offices. So enhancing cleaning protocols. So we have to have a proper enhancing cleaning protocol in place. Increase, ventilation. So HVAC systems that regulate air, they are common. So now we have to, going forward, we must consider ways to ventilate more with outdoor air to dilute airborne contaminations and also lower transmission opportunities. I'm sure Ted, with his extensive experience, can tackle on this subject more and to tell more about it. So then maintaining optimal humidity also. So because the viruses survive better in low humidity environments, tweaking our HVAC systems to obtain an optimal range of 40 to 60% humidity is an action that can be taken immediately for all the buildings, especially and hospitals and other places. So then leverage, hands-free tools, automation and voice activation. So that means we have to now thinking to build more smart buildings. So in our design, we have to also looking more how we can design more sustainable, more small building by limiting the needs to touch things in the work environment and reduce exposure to germs. So that's the key, focus we have as a designer to looking into it. And then, and then implementing, a screening procedure at the entries of our places,
Wonderful. Thank you, Payman. And Shawn, I just wanted to come and understand, because you were doing 3 hospitals in India, and you have an extensive practice, and you've got a very strong base in Mumbai as well. And India is a very, different problem in the sense of the population that we are saying. What are your thoughts in terms of, because Payman said, of course, one needs to look at, and the last word, which was really very close to me, on the sustainable aspect of it. And in India, we are trying to, and as Mr. Modi says, Swachh Bharat, meaning clean India. So Shawn, I'm sure these words resonates And what would you like to talk about India? And since you have a practice and you have 3 big projects going, yeah.
Thanks, Bibor, and thank you, and it's an honor to be part of this panel also. And I think just echoing what the doctor said earlier, that the infrastructure was not prepared for this. And I think that not only goes to India, but it goes to most of the cities and countries around the world. As a firm, as a global architecture firm, we have the ability we work all over the world. And we work on healthcare projects everywhere, ranging from Stanford University and NYU here in the US to a new teaching hospital on a health science campus, actually with Ted Jacob in Kuwait University, to multiple hospitals, including the 3 hospitals with AIMS in India. And what we've seen is that hospitals and entire healthcare systems anywhere have not been prepared for this. If you just look at India as an example, I think before this pandemic, it was 30,000 beds short, almost. Just in
Sorry. Say that again, one more time. What is
just in India, before this pandemic, the healthcare system, I think, was at least about 30,000 beds short within public healthcare system. So then push the pandemic onto this, and the healthcare systems aren't really prepared to handle the surge of patients. And so I think what we're going to see is a complete change in healthcare design and healthcare communities and systems as we go forward. To be able to prepare for this. And so the things that we will see, which has been talked about, and some institutions here in the US and Europe and others have prepared for this, but there needs to be scalability and flexibility. Scalability in the sense that healthcare systems need to be able to quickly expand, whether it's the EDs or conversion of other parts of the hospital to increase bed capacity, or within a community be able to expand bed capacity. But then there needs to be flexibility. So you need to be able to quickly convert the number of rooms within the hospital to acuity care or isolation. And that's what we've been doing a lot with our healthcare clients here in the US is converting a lot of those things. But I think going forward, every hospital, every healthcare system is going to think about this more. They're going to think about how they expand quickly and how they adapt quickly. But I also think post-pandemic, there's going to be a change in how people use the healthcare systems. There's a fear going to the hospital right now, right? So if you have to have a minor routine surgery, a simple outpatient surgery, maybe it's a very simple surgery. Nobody really wants to go to the hospital right now because of the anxiety of the pandemic. So I think we're going to see much more of a hub and spoke system where you're going to have increase in outpatient surgery centers and things like that, which are embedded in part of the community and much more holistic, and taking the fear out of medicine a lot more. So going into a 1,000-bed hospital, which has a surge, for a pandemic, and you have to do a routine surgery, people are putting these things off, and we don't want them to do that. So I think healthcare systems in general, we've seen this here in the US, it's happening in Europe, but we're going to see this in places like India and the Middle East and elsewhere, that there's going to be this expansion of outpatient surgery centers also. So there's going to be a complete change from this, a complete disruption, I think, of the healthcare system in every country.
Very well. I think that's 2 things. I think that has to be a mindset change at the individual level, at the society level, at the country level. And I think, Shawn, you said something very nice, which is expand and adapt. I think that is the kind of flexibility and adaptability one has to imbibe and move fast. And you make facilities and spaces which can scale up. Reza, getting you here because you're working and you know this stuff as India as a country, and you've been dealing it for a long time. What are the handicaps that you see in a healthcare space in India?
Hi, Vibor. Thank you for bringing me in, and thank you, Radius. It's a pleasure to be with such eminent panelists. I like your background. It's very, sustainable. It's green. It's got trees. So I think it's this thing on the background.
No, I kept something very light, so just to elevate the mood.
So, I mean, looking at India, basically the population of India is, I mean, the latest census that we had is almost 1.4 billion, and the entire bed capacity in government hospitals is, about 700,000. When you just do a breakup, it's 0.55 beds to 1,000 people. So, I mean, you can just, look at it that what is the inadequacy in the beds itself. So this is for not a pandemic situation. This is for the normal situation, like Shawn said. So we are short of beds in the first place. And then this pandemic came in, and it came as a surprise to the entire community, entire globe, actually. When we look at it today, also, leave alone the bed count, it's also your, the testing facilities. We do not have enough testing facilities. There's no proper provision for quarantine for the COVID-19 patients. There is shortage of beds, there is shortage of oxygen, ventilators, and even trained staff. We do not have proper trained staff to handle these kind of situations. And looking at, the pandemic that is there, it's a very contagious virus, and even with a droplet, it can just spread. So now going forward, if we look at the hospitals that we are going to be designing in the future, right now in India, you look at, 1,500 square feet per bed. And in the US, it's 2,500 square feet per bed. In the third world countries, it's still lesser, it's 1,200 square feet per bed. So when we look at the new designs, firstly, we will have to have the social distancing. And for that social distancing, we will have to give the patients or the bed count more area. So maybe we may have to go in for, instead of 1,500, we may have to go in for 2,000 square feet per bed. Now, this would be giving rise to, increase in cost, increase in affordability, increase in the, the area for the bed count. And the other thing would be your, once we create this, you got to have antechambers for this kind of, COVID-19 patients. So that would be another challenge. And going forward, of course, as Payman and Shawn mentioned, we would have to look at, the design aspect of it. We would have to look at using more antibacterial material. Even your elevators, maybe we do not use the touch buttons. We have some apps on the phone itself, which you could be using. So there is less of human contact. You do not touch, so if the railings, your handrails, your doorknobs, everything have antibacterial coating. So that would be the next, going forward. So.
Yeah, a lot of questions are coming, and that's a great participation happening, but I will reserve it for till we finish the first round. Reza, you said one thing, and we also see there is a surge in India of small hospitals coming up. You see a lot of small 100 to 120 odd beds, because if you look at full-fledged 1,000 bed hospital, it takes a good about 3 years, and it takes about 9 years for an ROI. So as a designer and from an owner perspective, where do you bridge this?
Is it for me?
Yeah.
Yeah. So, yes, we would have to look at, smaller hospitals, because you cannot have, larger hospitals everywhere, because this is a pandemic situation. But when you look at a non-pandemic situation, when there is this thing, how do you, fill up those beds? It would not be viable to do that kind of hospitals. So maybe in the larger metros, we have the larger hospitals. And when you go to smaller towns or cities, you got to make them smaller hospitals to make it more viable and to make it more effective.
Awesome. So, Ted, I'm now coming to you, because you had really work with Shawn, Payman, and everybody. And you have like been the kind of, in Hindi we call Sutradhar, or somebody who really anchored the whole project together. So what is your take on this 4 decades strong, illustrious career? You would have seen lots and lots. And now that we are gripped in such a tight situation, what are your thoughts, and what is that you think, and what is that you would like to tell the owners of the hospital chains and the designers? What would be the new construction methodology they need to adopt?
Okay, thank you, Vihar, and it's a pleasure to be with this distinguished panel, and welcome to our guests. Let me backtrack a little bit through my career. We've seen epidemics come along like the TB, SARS, Ebola, and as these effects have developed, the codes have changed. And with this, the new epidemic is just this monumental impact on the healthcare industry. With the previous epidemics, the codes have changed. For instance, like when the TB came, there was a code change. We'll have one isolation room per every 10 to 12 patient rooms. And now with this, the new epidemic, it seems like the whole hospital should be like in a negative isolation rooms. So like everybody on the panel is saying, there's definitely going to be code changes and also some regulation changes. So with that, with the design of hospitals, like for future proofing, with these change, with this new epidemic has come, I see that the hospitals will basically go have a 100% outside air system once coming through the building and exhausting all of that air. So I see that being a big change in the designing of hospitals. In addition, as we have experienced these ventilators and a design on the mechanical systems, like on the medical gases, the oxygens, and the medical air, usually we design like 20% of the patient beds will be having these ventilators. But now, well, probably the whole hospital should be make ready to be able to handle something of this scale. With the emergency projects that we had a lot of them coming through our office. I've been extremely busy. One of the main primary things, like they were lacking, the hospital system was lacking the oxygen. And so by kind of future proofing of something of this sort, basically we need to simple things, basically increasing the size of the oxygen piping, so you not have bottlenecks delivering the oxygen. And that should be basically to be able to handle all of the patient rooms, also the ICUs and the ORs as well. So with that being one, with the 100% outside air being the other, the Shawn and Payman handle the architectural part. So it's going to be many changes on the architectural part as well. Where it's going to be empty rooms, isolation rooms, being really careful on how the progression of the patient coming into the hospital, and have got experience all through, going being a regular patient or going through ICU or surgery or other departments. So we're going to be seeing a lot of these changes coming up. The other thing, if we have an epidemic like this, as you can see, we've been struggling, trying to scrounge around to find spaces where we can expand into to have this huge surge of patients, turning parking lots into kind of hospitals, or changing gymnasiums or other types of building into makeshift kind of patient areas. So it should be, the hospitals should be ready to be able to handle these patients was they're close to the hospital. For instance, they could change the parking structure that they have into something of that sort. They make it kind of epidemic ready, basically having the basic infrastructure ready so you'll not be scrounging at the last minute trying to find spaces. So that'll be another thing that the designers will be thinking about, and basically future-proofing our medical system into something that can handle this sort of epidemic. Thank you.
Wonderful, Ted. I think I would completely agree. And I think you said there are so many changes and makeshift in terms of parking. But unfortunately, Dr. Ashutosh and Dr. Rana, India unfortunately doesn't have that kind of facility. We don't have that kind of parking which can actually be turned into kind of another containment zone. But there are some very innovative out-of-the-box solution that is emerging, which are like the train coaches being converted. And also in terms of schools, been given to migrants, where you have already, a big courtyard where you can do your kitchen, you have toilets, you have housekeeping staff, you can contain your migrants. So we've come to the space utilization very quickly, and I see a surge of questions coming, and I want to bring my colleague Sanjay Bhan very quickly. Sanjay, can you unmute your mic, please? And Sanjay, I think you would like to take one poll and a question here. Sanjay, can you hear me?
Yes, I can hear you, Vibhor. Thank you very much. I have one of the questions for one of our attendees. They're saying, what will be the future guidelines for the upcoming hospitals in terms of isolation of the infected patients?
I think this I would direct the question to Dr. Rana and Dr. Ashutosh. And Sanjay, okay, so who's the gentleman? Do you want to introduce that gentleman?
Yeah, he is Mr. Surendra Kumar from Astron Healthcare.
All right. So, Dr. Rana, would you like to make a comment, and then we will have Dr. Ashutosh. Sir, could you unmute your mic, please? Dr. Rana, can you please unmute your mic? Yes, sir.
The important problem we are facing right now is that of isolation, what the person gentleman is asking, and especially in central air conditioned hospital. Our hospital usually used to have windows. I think we were very comfortable, but for last 8-10 years we have converted the whole hospital to now central air conditioned hospital. We are finding it very difficult to run our OPD services. This is the reason that we have to. I was listening to the engineers, Perkins and Shawn and other person, that in future you had to build a hospital not only for COVID, but also to isolation is a really important thing. How do we isolate? Right now, in fact, he has asked question. I was going to ask this question from maybe Payman or somebody else who can reply. Then how do we handle our central air conditioned hospital right now? How do we run our OPD services now once lockdown is lifted again? So probably you have to answer this question.
I will take, yeah, Ted, I think, would you like to, where Dr. Rana left, and before Ted comes, Dr. Ashutosh, you want to make any quick comments on that question?
No, I think, the Ted would be the right person.
Super. Yeah. All right. Very well. Yeah, Ted.
Thank you. As I mentioned earlier, going with the hospital to have 100% outside air coming through. I know a lot of hospitals in India, they do not have that kind of a system set up. But I think that in the next wave of hospital designs, that should be an important feature to include in the hospital system. And as far as the isolation rooms, one thing that's different doing isolation room than a regular patient room, the number of air changes that's going through the room. Like in a regular patient room, you have 6 air changes, versus isolation room, you'll have more like 10 air changes. So the air quantity flushing through the hospital will also increase. And also the supply air, you see the supply air register at the ceiling. And in an isolation room, you'll need to have that, the exhaust air. Instead of at the ceiling, would be at the patient head. So all the exhaust will be flushing through there. Those are the code requirements for an isolation room. So I think we'll be seeing more of that. The air treatment is very important. You always want to design from clean site going to the infectious site. So, I see that being a big change coming through.
So Ted, there would be a lot of HVAC people actually watching. So any particular messaging to any brands or companies who are dealing in HVAC solutions?
Can I add, before, excuse me, can I add one more question for Ted? It's similar to what you are asking, Ted.
Yeah, please.
Yeah.
Go ahead.
Ted, we have a lot of questions coming with regard to the HVAC. In US and Europe, they use the air-cooled system in hospitals. But most of the hospitals in India and elsewhere are using the water-cooled system. So how do we see the future keeping the current pandemic crisis in mind?
Okay, let me interpret your question. You mean once it could be using a package air conditioning type units versus like a water-cooled type of system? Depending on the size of the hospitals, basically the water-cooled air conditioning system is the preferred method of doing it. One, you can have better control of the temperatures going to all different parts of the rooms in the hospital. Because with your temperature, and Payman mentioned earlier, the humidity part as well is very, very important. So you need to be able to have very controlled environment, temperature, humidity, also the air pressurization within the room, between the rooms.
All right. Thank you, Ted.
Yes,
sir.
Can I ask one question on Ted?
Yes, sir. Sir,
please go. I just want to know that, we are facing right now the problem, that we have H1N1 about 10 to 15 years back. The policy of isolation for that disease was totally different. The policy of isolation for this COVID is totally different. So I think you all Indians have to make hospital near fitter the way that applies to everything. Well, isolation, I think something like what you are asking, the humidity, but most importantly, that sort of cross contamination from room to room. It didn't matter in H1N1, but in COVID it really matters that in centrally air conditioned rooms where 12 rooms are attached to one air condition, then you are transmitting to all the rooms actually. So in fact, right now we are fortunate to have two hospitals where split ACs are working, so they are quite suited to this. And we are creating windows, they are open, breaking the glasses. What you tell us something that for future, what are you going to see? Because we are constructing a new hospital, 1,000 bedded hospital, one more hospital, and we have to take all these things into consideration.
Sir, that's very good. Yeah.
Can we take the poll, Rohan?
No, 1 second. 1 second, Sanjay. Just let Ted finish it. Yes, and Ted. Go ahead, Ted.
In hospitals, there are code requirements. Every type of room needs to have certain pressure requirement. For instance, a regular patient room has a zero pressure differential requirement. Then operating room, you'll have a positive pressure. You want, because it's clean environment, you want air to go out from the room. Then isolation room is a negative pressure isolation room. So all the air from the outside going into the patient room, so it will not be affecting other parts of the hospital. So your system needs to be very flexible in controlling the pressure differentials in the hospital. So which comes into technology, controls, and all that. And we do that all the time. But once you're in the designing of healthcare systems or for hospitals, it's become second nature. This is what you do, and that will pretty much eliminate the spread of infection. I hope I answered the question. Yeah.
Ted, you made a very good comment, and I think we're feeling very good that we have this platform where we see there is a lot of exchange within each other. That's very encouraging, and I'm sure we will pass on Dr. Rana and you the connect. We'll connect you so you can take that discussion. My colleague Rohan, would you like to do a poll here very quickly?
Yeah, surely. I'll do it.
So we just want to see what our audience have to say and to gather, because there are many questions. The question says, does Indian government need to allow more private hospitals to treat COVID-19 patients? Panelists can also vote here. Does Indian government need to allow more private hospitals to treat COVID-19 patients? There is only three things: yes, no, uncertain. I mean, you can also vote, everybody. All right.
Infrastructure, yes.
Yeah, sure. I think that is very unanimous one, Reza.
Well, Reza, we are collaborating well, between architect, structure, MEP, so we have no issues. Don't worry.
Yeah, Sharon, you can take this away. Take it down. Thank you. So I would like my colleague Rita, as I said, who's the editor of Healthcare Radius magazine and a very, very profound journalist and with a very strong following in the healthcare sector. Rita, over to you.
Yeah, I would like to ask two questions to Dr. Rana and Dr. Raghuvanshi. Is that what are the challenges that you faced, infrastructure challenges, when you converted two of your hospitals to all COVID hospitals? Dr. Raghuvanshi, you begin. Because you converted the Vashi hospital to an all COVID hospital.
Yes, yes, we did. But there were serious infrastructure challenges because we didn't really have a split AC kind of system. There was centralized AC, and there were and there weren't enough number of isolation rooms. They were just, the entire hospital had only two negative pressure rooms in the system. So what was done was primarily we just sort of got exhausts put in all the rooms. We segregated the areas, and only physical barrier was there in the area where the suspected patients were there. So it wasn't an ideal solution to start with. But as we are going through this further, we have stopped the centralized air conditioning, and we have put window ACs, and we have segregated the rooms so that the air circulation doesn't happen.
So how long did it take for you to convert it into an all-COVID hospital? Because some took 7 days, some is taking 2 weeks.
Yeah, it took us about a week, but there is another hospital which we are doing along with Medanta, Artemis, and Paras Hospital together. We all are working with the VPS group to convert the Meteor Hospital, which is going to be a 150-bedded hospital, COVID dedicated facility, which will be functional from Monday. So that took about 4 weeks to do. Okay,
thank you. So coming to Dr. Rana, would you like to say, when you converted the first hospital in the group, so what are the infrastructure challenges you faced, and when you did for the second hospital, did you do it in the same way or did you do it differently? We can't hear you.
Sorry. First hospital was only 40-bedded hospital and having all rooms split ACs. So it was not, and fortunately, it was like that. It took only 48 hours for us to prepare it for making the COVID positive hospital. The other hospital, which have been approved, or the government has given us instruction about a week back, they wanted us to do it within 2 days, but that is not possible. And now, for last 6-7 days, people are working. Fortunately, there is no problem with air conditioning there also. The problem is to create a zone, green zone for the staff. So we are putting some wooden partition. That is taking 5-6 days. But let us say, unfortunately, some hospitals are centrally air conditioning, then it is a real challenge now. We are having that challenge about OPD services, OPD room, where we want to start OPD next week. And there are a lot of challenge of air conditioning. We are taking consultation from US, other people. How they are doing, how can we do? But right now, I just want to ask the panelists here, those who are here, that we are trying to put a resource in every room, and at the same time, engineers are finding some way to increase the airflow. And that is also going to take at least 10 days to make those OPDs functional. But we are already on the job for the last 10 days, and probably maybe by Monday we'll be ready with this sort of partial solution. As far as COVID positive hospitals are concerned, fortunately, our present 2 hospitals, They are not central air conditioned by, they are having split ACs or individual room AC. There you are not facing any problem.
Okay. I have a question for Dr. Raghuvamshi. Dr. Raghuvamshi, do you think it is more challenging for your hospital, which has both a COVID ward and operating as a multi-speciality hospital, or to have a full COVID hospital? The challenges are more when you have both?
Yeah.
Yeah, I mean, there is no
Challenges in terms of infrastructure.
Yeah. No, it's the hospitals have not been built to handle this kind of complete isolation. And then second thing is patients don't have a kind of just a specific COVID disease. They need to go to the imaging suites. They need to go to the ORs, etc. So just COVID does not mean that they can be treated in a completely isolated facility. So I think the hospital has to be a complete hospital in order to treat critical patients who are suffering from COVID and have multiple.
So how do you ensure that the mixing doesn't?
So there has to be a physical barrier, and that's probably the reason why the entire hospital needs to be designated as COVID in order to keep that separation, until you can physically create two parallel infrastructures.
But the question is that if I can, because I fully agree with Dr. Raghuvamshi, and probably we should have totally COVID positive facility. But in this scenario of COVID, when you are seeing that in India 70% are asymptomatic, there is a real challenge in designated COVID negative hospitals. We don't know who is positive, who is negative. It is much more easier to manage the COVID positive hospital, but I think we are going to have very real challenge once this lockdown will be over. We will be having a lot of asymptomatic patients in COVID negative hospital also. So we have to take some universal precautions, or eventually I think after maybe 5-6 months, we have to go out of the sphere of COVID. I don't know how to, but this is but certainly theoretically, I believe that COVID positive facility should be totally separate once somebody is separate. That can minimize the cross transmission.
Igor, is muted. Your mic is muted.
Yeah, I think this is something which we really have. Thank you, Sanjay. We heard the challenges faced by Dr. Ashutosh and Dr. Rana. I mean, they're very eminent personalities in India in healthcare space. Shawn, what is that you are hearing in US in hospital premises and spaces? What are the challenges emerging there?
Well, the challenges, first of all, were, as I said, expanding and adapting to the COVID surge. But I think beyond this, what we're seeing is a lot what Ted mentioned, that the hospitals are going to be designed for, as I said earlier, to be able to scale up and to quickly adapt. So designing, more ability to quickly adapt isolation rooms. So having more rooms which have an ante-room before the patient room, wards which can completely be shut off and isolated, so it's a full isolation unit. So you're going to see much more flexibility in the design of hospitals, and we've seen this already in NYU, which is a big client of ours here in New York already. In a lot of the new buildings already had built in that adaptability. And so we started working with them back in January to quickly convert a lot of the rooms there to isolation rooms or isolation wards. So hospitals are already thinking about this. It's already in a lot of the things that we've done. Stanford University is another good example. Ted mentioned, here in the US, you usually have a parking facility which is next to it. I know India is a little bit different. But Stanford University, the entire ground floor of the parking garage, which is right next to the ED, is easily expanded to take on the surge for a pandemic. So this is going to be the new norm. Even if you don't have a parking facility or something, you're going to have adaptability that you can quickly add on patient rooms to accommodate a surge which comes. So that's the big change in hospital planning. So much more flexibility and adaptability within the existing hospitals, scalability around the hospital if you have to quickly ramp up for a surge in the pandemic.
Shawn, thank you. And I think just to let you know, in India also, I think there is a lot of out-of-box thinking happening, and corporates are, coming up. And I think Wipro, through our healthcare radius, I read this on a newsletter yesterday. Wipro is now remodeling one of the facility, Dr. Rana and Dr. Ashutosh, in Pune for a 450-bed facility. So there is a lot happening in our country, and corporates are coming. People are thinking out of the box. People looking containment zone. Finding new ways to handle it. Reza, I just wanted your sense, because you work in both the geographies extensively. What is that advice would you like to give as a designer? Keeping in mind that, we have owners of two large hospitals here. The approval processes are very complicated and very tedious. I'm sure Dr. Rana will agree, and so would Dr. Raghuvanshi. The approval processes to make these hospitals are very, very complicated, and the whole project takes about good 3 years. What is, as a designer, would you expect from the government? How would you like government to ease out this so that we show speedy progress, flexibility, and every eminent panel said, Shawn said adaptability, then he said expand, Payment said about the new sustainability, the new technology. What do you think as a designer you expect, where you can actually give your creativity a complete way to blossom out and make these spaces effective, efficient, adaptable wellness spaces? Reza, unmute your mic. I think I spoke a lot.
That's a lot of things in one question.
Yeah.
It's a good one. Basically, I think the government should look at, re-looking at the code systems that we have, the regulations that we have, because we do not have anything actually as a proper code system for hospitals. Hospital is a necessity. We've been looking at all different buildings, different architectural buildings, but we haven't looked at hospitals very seriously. It's only, I think, a couple of years that people have started looking at hospitals. So we should look at it more deeply, and the government should give us more incentives to do hospitals. Like, not only government doing hospitals, private organizations, private entrepreneurs, private, multinationals to do hospitals. They should give them more incentives. Today, like you get a lot of, when you do a hotel, you get a lot of incentives. You should have a lot of incentives to do hospitals, because as I said earlier,
Reza, just to interrupt, also the hotels face almost like 65 to 75 licenses to run, but that's on the other side. Yeah.
I got it. I know that, hotels, but still, you got a lot of incentives on the this thing, because you're bringing in dollars into the country, you're bringing in tourism, so you get a lot of incentives. So hospitals also should be given that kind of incentives, and then you can really make it more viable scenario. So that's from the government side, but from the architectural side, I would say we should have, like Shawn said, like Ted said, we should have flexibility in planning, which can be easily reorganized, to face these kind of threats. Then controlling people's movement into the hospital. As far as possible, I think we should not encourage people to enter into, like in India, we have this thing, one person is sick, there are 10 family members, they come into the room and they all want to visit this patient, and it's supposed to be very good to go and meet a patient, but this should be discouraged. You should come up with the virtual. If you want to meet your patient, it's virtually. You do not come in to the hospitals to meet the patient. It should be virtual. Even your treatments, we should get into more of a technology kind of a thing, robotic kind of a thing, where we have the robotics treating the patient more than the human interaction. So I think these are some of the things that we should be looking at going forward in our hospitals in India.
No, very well, Reza. I think very well summed up. And I think we have to look deep. We have to look people movement. We have to adopt, embrace technology, and government definitely needs to incentivize so that our designer friends come in. People like Ted find India as a fertile bed. But let me take very quickly.
Vibhor, sorry, I'm interrupting, but
please.
A lot of the rural areas, there are not proper hospitals still today. People have to travel miles to reach a healthcare facility. So I mean, we should encourage people to go into the rural areas as well and put up healthcare facilities.
No, absolutely. I belong to a very small city. I mean, my hometown, and I mean, most of the people and the folks watching would know it's Rabat. To many years, when I was studying, there were not any proper hospitals there. Dr. Rana, that was a literal truth, and Dr. Raghuvanshi, we never had anything there. Yeah. But later on, I think ever since with the doctor and our Prime Minister, Mr. Modi, I think virtually the whole India is covering, and I see so much of scalability, not only from healthcare, virtually every side we see the development and infra going up, right? So Dr. Raghuvanshi and Dr. Rana, I would definitely like to take your view on the complexity of making hospitals, the elaborate process, and what are your views, sir? Dr. Ashutosh, Dr. Rana, please go ahead. Yes.
Yeah, definitely we require more hospitals in two-tier, three-tier cities. But as Dr. Kabul was telling that 70% population is residing in villages, and I also belong to a small village. Fortunately, I'm running a small hospital there, which is attached to Nungara Hospital. But what I feel the model has to be that we have to create small surgical centers in villages and small cities. And these centers must be adopted by big tertiary care hospitals, be in the government side or non-government side. And doctors from that area, they should go right now. A lot of people are ready to make hospital anywhere, but you don't have medical manpower. You don't have doctors, you don't have paramedicals. But so it is responsibility of tertiary care hospital like Fortis Group, Apollo Group, Gangaram, or AIMS, and so many of these things. People from there, they should go regularly. And I think in future, we all know the technology of ORs right now. We all know the isolation room, how to create H1N1 wards. But those are only small facilities in a particular hospital. Most of the hospital, Dr. Raghuvanshi agree with me that India over last 20 years, since this corporate culture came into being, all hospitals became centrally air conditioned. And that is coming in a very big way to treat pandemic like COVID right now. So in future, you people have to think like that hospital is ready to take this thing. So small isolation room cannot take care of the pandemics or endemics. So it is very important that hospitals are constructed like that we are able to treat all sort of diseases, and we can create isolation the way we want it. That is a challenge in front of FATEM and SONS and TED, that you should try to create hospital where we don't have to create facility instantly whenever some epidemic comes in. But the hospital should be able to have isolation facility all the time. Right now, all the hospitals, they're having few isolation facilities or few ICU rooms where point pressure things are there. But something we got to think over that. Thank you very much. It was a really very, very nice discussion. And thank you for inviting me. And thank you, Rita, for inviting me.
Thank you, Dr. Rana.
Thank you.
Before your mic is mute, you are mute.
I was just saying, sir, bear with us. We are almost to reach, and I wish we had a little more luxury of time. And my backend team also says there is a poll. So Rohan, you can go with the poll as I go to Mr. Ashutosh, and I will straddle all my panelists for the last word. Rohan, you can put the poll up. Can you hear me? Yeah. So gentlemen, and all our viewers who have been very patiently been with us throughout the session, the next poll is, should government fix the tariff for private hospitals treating COVID patients? You have to answer. There are three options: yes, no, answer, uncertain. Should government fix the tariff for private hospitals treating COVID patients? The answer is yes, no, uncertain. While this goes up, Dr. Ashutosh, your thoughts on where Dr. Rana left?
Yeah, no, I think it is true that we have a lot of requirement for infrastructure in smaller towns and rural areas, etc. But I think the challenge in India has been more about human resources and manpower, physicians, especially what Dr. Rana pointed out. I think that is a very important constituent of this problem. And I think that needs to be addressed with a certain set of urgency. How I see the healthcare ecosystem changing in future is one of the things which earlier Shawn said, and that the surgical centers, and Dr. Rana mentioned that as well. I think the way people access healthcare itself has been undergoing a transformation even before this epidemic came into picture. And I think that will happen, and the future hospitals would definitely get influenced by that as to how people access healthcare, and not that many people would like to flock into the hospitals as they used to do in past. So the infrastructures will have to be sort of taking care of what people are wanting to access. And also, if we incorporate all the technological elements and design elements which are required, then the sustainability of the healthcare in India, where majority of expense comes from out of pocket, becomes very, very difficult for both the patients as well as for the hospitals. The current situation in India is very strange, where the hospitals are not able to survive because of the kind of price controls they have. And the question you put, whether the government should control the price, the hospitals are already not able to survive. On top of that, if we control the price, that is going to kill the whatever inadequate infrastructure you have. So I think there is a problem. People do not have the ability to pay, so the prices have to come down, but that subsidy has to come from government. That cannot be privately financed. So I think this is one thing which we have to remember as we go in future.
No, very well. I completely agree.
And Dr. Raghuvanshi,
sorry, sir?
I have a different opinion. I am strongly for fixing the price on pragmatic basis by the government, because so that the whole non-corporate hospital, like corporate hospital, they are facing a lot of unnecessary criticism. Nobody is thinking that they are giving services, and providing services not easy. Right now, let us say your hospital declared COVID, our hospital declared COVID, one wing, our main hospital is non-COVID. But once you will be having only say 20% occupancy, 30% occupancy, who's going to take care of staff salary at that time? That is what government should be deaf for that. So that is why they should fix on the prices for everything. They should take into consideration all aspects of that. Otherwise, the private sector is going to be under criticism from government side. They feel that they are looking at us and we are looking them, and that is not true actually. But I know that this is very difficult to question this way or that way. But I am for that government. If government is criticizing, public criticizing us, then it is the government duty to fix it on pragmatic side. But I can agree with you. The state government asks that honor our panels. If we honor Ayushman Bharat or other panels, the hospital will not take it 1 week to get closed. They can close down within 1 week. So there is no pragmatic approach from our side. Otherwise, the state can have a pragmatic approach in particular city, depending on city, location of the hospital, type of treatment they are providing. It is possible to fix up the prices. But who will bell the cat?
No, that's a very good point. Who will bell the cat? And let me get to Payman. Payman, can you unmute your mic, please? Payman, can you unmute?
Yes.
Payman, I think, we are just running out of time. Time we got so engrossed, never realized the watch. Payman, what would be your parting thoughts, both to India as a healthcare sector and of course from US? Just the parting thoughts from every gentleman, every panelist here. Yeah, Payman.
I understand. Sure. Yeah. When we look at the geographic places, such as India with a dense population. So I think with the 80% of infection diseases transmitted by the touching contaminated surfaces, this hands-free future could well catch on. So this is what is like I'm thinking, and I really advise, in such a dense cities, the designers should go with the hands-free future, touch less, to design, the hospitals, other facilities, buildings. So we need to looking to eliminate direct contact, with the communal services, right from the street, to the working station. So that is, what I can advise and conclude, from my part.
Thank you, Payman. Shawn?
Oh, thanks, Bibor. And I think, like I've said, we're going to see radical changes in the healthcare system, but we've seen this already starting before the pandemic. It's just going to accelerate after the pandemic. But I think the biggest change is we're going to see this is going to have a psychological effect on how we live, work, play, and heal. And it's going to affect every part of our society. And I think as designers, that's what is really the interesting dialogue for us. It's going to change how we design healthy and resilient communities. It's going to change how we think about our education system. It's going to change how we think about our workplace, with the majority of the workforce being remote. It's going to change how we live. And I think that's the interesting part of the dialogue after this. And that's really what we've been starting to focus on. There's going to be much more focus on health and wellness in everything that we do. And there's going to be this acceptance that we can have meetings like this and be remote, and we don't all have to be in the same room. So there's going to be a radical shift in how we live in our society, and I think that's going to be interesting.
Well, very nice. And I think in the same, virtual meeting, find solutions like we found today with Dr. Rana and Ted. Reza, your last thoughts. Unmute your mic.
Yeah.
Reza, unmute your mic.
I think moving forward, sustainability is the only mantra that would save the world and, contain COVID-19 and other viruses that would be, coming to the world. So that's going to be the new normal that we got to live with.
Yeah. Ted?
Yes,
Tell us also in India, what should the HVAC people should now adhere to?
One thing, as I mentioned earlier, think about, I know one thing, the Indian hospitals should set their standards to design hospitals based on international standards. I've experienced that many hospitals are kind of makeshift and not quite meet the international standards. So that's a really good start, because all the codes, requirements, what have you, they're all spelled out in those standards. One thing I want to mention, like in the, we have different types of hospitals. Like we have different specialty. We got general hospital, we have women's, children's, we have cancer. And with this COVID, we're trying to make these specialty hospitals also to handle infectious kind of patients. And I think there should be like another category, which in some countries say, we're designing like infectious hospitals that are basically designed for infectious people. You don't want to, if you have the other specialty hospitals, you don't want to bring in an infectious person going through triaging and going through all the process goes through before it goes to the patient bed. It's going to affect the whole hospital pretty much. So it's very, very, very hard to control that, no matter what you do with HVAC or with architectural planning and what have you. So I think there'll be a trend of designing more of infectious type of hospitals.
Okay. Rita, I would like my editor. Do you want to make some comments here? anything that you...
Comments. I'm very sorry that my connection got disconnected, and I think it was a very wonderful panel that we have today. They have given a lot of suggestions, and one thing I think, one main thing that all of them pointed out, that hospitals for tomorrow will be built in a different way. Okay, they will be built in a way that we keep that infectious diseases would be there in the future, and how do we work around it, and how the government can also support the private sector so that the hospitals are more sustainable. Especially the private hospitals do contribute in a major way in fighting the current pandemic, and which how the government can help the private hospitals in this battle, because the government cannot do it alone.
So I think, I see a great smile on everybody's face, and I definitely was very hungry to listen to more. And we see a lot of questions stacking up. My team in the back end will make sure that we ensure the answers to them. I firstly want to really thank each and every panelist for taking time out. Payman, Shawn, Dr. Ashutosh, Dr. Rana, Ted, Reza. And I think just to sum it up, I think we straddled across a lot of segments. We touched a lot of things which are to the very core to it. I think firstly, I think it's a great thing Dr. Ashutosh and Dr. Rana are doing at the moment. So this is something we really want to thank you both, and especially all our designer friends from overseas. They talked so many things, the challenges that we face on the infra side, the human resources, access to healthcare has to be, looked very differently. I think this is a moment to learn and unlearn, because the more you learn, then you have to really unlearn to make sure that you have space to inculcate new discipline, new practices, the way you look at the problem, the perspective has to be changed. And I think the design elements and the design mantras have to be changed. Shawn said about the way we work, the education system. I think we need to flag off everything from the individual to the society to everybody. Then only we see a change in the movement, the way healthcare in India will evolve. I think future at the hands of such learned people like you, I think we are in safe hands, and more in terms of our leadership with our very dynamic Prime Minister, Mr. Narendra Modi, and I think wonderful healthcare professional, Dr. Rana, Dr. Ashutosh, and all the brilliant minds from the US, and Ted with enormous 40 years experience are already ready to impart learning to the folks in India who want to learn from them, collaborate with them, ideate with them, come together, as Shawn rightly said, in this room. More, I think that's where it is. And just again, wanted to thank one more time. And I think Healthcare Radius, which is like really at the forefront of the healthcare industry, we obviously come out with our daily newsletter. You will see the coverage of this session in a very exhaustive manner in the subsequent issue, which Rita will ensure. And I think she will really she's got a lot of thoughts as much as I got. So ladies and gentlemen, and all the viewers, I'm very sorry to see so many questions still coming in chat, so bear with me. Thank you and lovely. I wish you all a very, lot of safety, happiness. Namaste from here. Thank you, everybody. Thank you.
Thank you each, everybody.
Thank you.
Thank you.
Thank you, Bibor. Thank you, panelists.
Pleasure.
Thank you. Thank you. And one last word. This is just the thread of a discussion. We want to continue this discussion going forward. So we don't want to stop here. We will be with you next time soon. Thank you. Thank you once again.
Thank you.
Thank you. Bye-bye. Bye, everybody.